So now I will talk a little bit about how the affirmation model began. The use of gonadotrophin-releasing hormone agonists was first proposed to suppress puberty in children with gender dysphoria in the mid-1990s. This was because researchers were noticing that transition in adulthood failed to resolve mental health problems. There was sharing of information between 3 gender clinics operating at that time: the Dutch, the Boston Children's Hospital under Norman Spack, and the Tavistock's Gender Identity Development Service in the UK. These groups worked together on the Harry Benjamin International Gender Dysphoria Association Standards of Care for Gender Identity Disorders, 6th version, which was published in 2001. The Harry Benjamin Association changed its name to WPATH in 2007. The Harry Benjamin Standards of Care noted, before any physical intervention is considered, extensive exploration of psychological, family and social issues should be undertaken. Adolescents' gender identity development can rapidly and unexpectedly evolve. Identity beliefs in adolescence may become firmly held and strongly expressed, giving a false impression of irreversibility. More fluidity may return at a later stage. For these reasons, irreversible physical interventions should be delayed as long as is clinically appropriate. Pressure for physical interventions because of an adolescent's level of distress can be great, and in such circumstances a referral to a child and adolescent multidisciplinary specialty service should be considered. However, they gave the green light to puberty-delaying hormones as soon as pubertal changes had begun, on the basis that A. to gain time to further explore the gender identity and other issues in psychotherapy. This is because back in 2001, they did not realise that puberty blockers freeze the child into their gender dysphoria. They didn't realise that puberty blockers prevent a child from healing in their gender dysphoria through the course of important physical changes and social experiences occurring during adolescence. And the second reason for puberty blockers was that they were also focused on a cosmetic result from avoiding puberty, and this likely reflects that only a small number of children presented with gender dysphoria back then, and it was predominantly male children. The standards of care note that, to be eligible for puberty blockers, the child should have demonstrated an intense pattern of gender dysphoria throughout childhood, which had increased at the onset of puberty, and the family was supportive. What is surprising about the widespread adoption of the affirmation model across the Western world is that it is based on a very poor level of research evidence. The use of puberty blockers in children was rare until the Dutch researchers published data regarding the first 70 adolescents referred to the Amsterdam clinic between the years of 2000 to 2008. The 2 studies published in 2011 and 2014 are about this same cohort of patients. These studies have been used as the basis of the Endocrine Society's 2017 Clinical Practice Guideline and the WPATH Standards of Care. So let's look at the first of these 2 papers, which was published in 2011. The subjects of the study were children who received puberty blockers between the years 2000 and 2008 after being diagnosed with gender identity disorder, which was persistent since childhood. They had to be living in a supportive environment and to have had no serious comorbid psychiatric disorders. So the cohort of this study is quite different to the cohort of children presenting to gender clinics these days, who have a high level of psychiatric comorbidity and family dysfunction. The subjects were given puberty blockers in Tanner's stage 2 or 3. They had undergone a comprehensive psychological evaluation with many sessions over a long period of time. The subjects were assessed using the following measures: the Child Behaviour Checklist, Youth Self-Report, Beck Depression Inventory, Spielberger Trait Anxiety and Anger Scales, the Clinician-Rated Children's Global Assessment Scale, the Utrecht Gender Dysphoria Scale, and the Body Image Scale. These measures were given to subjects just before starting puberty blockers and again just before starting cross-sex hormones. The time between these two assessments was, on average, almost 2 years. So between the years 2000 and 2008, there were 111 adolescents who met the criteria to enter the study and started puberty blockers. However, participants in this study were the first 70 adolescents who started cross-sex hormones. There was no explanation given as to why the study cohort dropped from 111 down to 70, which is a loss of 37% of subjects in just under 2 years. Amongst the 70, they were almost half male and half female, and 88% reported being same natal sex attracted. The average age for starting puberty blockers was very late compared to today's standards, just under age 15 for males and just over age 15 for females. The subjects received extensive or other social support and were regularly seen by the clinic's psychologists and psychiatrists. The study found that the adolescents about to start cross-sex hormones had slightly fewer behavioural and emotional problems and reported fewer depressive symptoms. Feelings of anxiety and anger had not changed. General functioning somewhat improved. So now we should look at the second Dutch study that underpins the affirmation model. It is the same cohort of subjects. However, in this study, the number of subjects has dropped to 55. The study is of 55 young transgender adults, 22 natal females and 33 natal males, who had undergone gonadectomy at least 1 year earlier. The mean age of the subjects was 20. Regarding the 15 that were not included in this study, the researchers explain that 6 of these were not yet 1 year post their gonadectomy, but they do not give an explanation as to why they stopped the study early and didn't wait to include these people. 2 subjects are listed as refusal and 2 failed to return the questionnaires. 1 is a dropout. The researchers didn't explain why, after many years of attending the clinic, these young people weren't willing to engage. 3 subjects were not medically eligible for surgery due to obesity and diabetes. 1 natal male died due to the complications of vaginoplasty. This is because when males in Tanner's stage 2 are given puberty blockers and then estrogen, their penis remains small and there isn't enough skin to make a vaginal tube, and so the surgeon has to use part of the colon, which is a much more dangerous surgical procedure. Only 40 subjects out of the 55 had complete data. A large number of measures were used. On the measures, the researchers found that, compared to prior to pubertal suppression, the natal female subjects had reduced anger, anxiety and externalizing behaviours. Natal males showed the same or slightly more symptomatology on these scales. The researchers reported that the gender dysphoria had resolved. Now I want to outline the main criticisms of these studies. The first is that there was no control group. We don't know how the subjects might have naturally changed in their gender dysphoria or other psychological measures as they aged. The average age of starting puberty blockers was 15, rather than 12 as outlined by the protocol. This makes the outcomes less applicable to current approaches of starting puberty blockers in Tanner stage 2, which is age 10 to 12. The children studied are different to the current population of children presenting to gender clinics. It was a highly selected group of children with long-standing childhood gender dysphoria, no mental health comorbidity and strong family support. The study has a very short follow-up time frame. The findings are only from 12 to 18 months following gonadectomy. The intervention included regular psychologist and psychiatrist appointments and was not just medication and surgical interventions, which could have led to improvements in psychological functioning. There was a high level of bias. Only the most successful cases at each stage were included in the reported results. From the 111 of the first study dropped to 70 subjects without explanation. To participate in the first study, the participant had to be ready to start cross-sex hormones. In the 2014 study, the sample is skewed towards those people willing to undergo surgery. One of the main findings of the studies was that the gender dysphoria resolved. However, this outcome was achieved because the researchers swapped which version of the Utrecht Gender Dysphoria Scale was given to the subject between the start and the end of the study. According to the 2014 Dutch study, gender dysphoria scores on the Utrecht Gender Dysphoria Scale plummeted from a near maximum of score of 54, where the maximum 60 at baseline, to the near minimum score of 16, where the minimum on the scale is 12, after the final surgery. The switching of which Utrecht Gender Dysphoria Scale was given to patients entirely invalidated the study's main finding. Rather than a true resolution of gender dysphoria, the drop in gender dysphoria scores was the result of switching the scale from female to male versions and vice versa before and after treatment. So you can see, if the subject was a natal female, at the start of the study they were asked questions such as, I prefer to behave like a boy, which they would strongly endorse. Every time someone treats me like a girl I feel hurt, which they would strongly endorse. I love to live as a girl, which they would strongly disagree with, and so on. Then once they had undergone pubertal suppression, testosterone treatment and a double mastectomy and removal of their ovaries, they would be given the male version of the questionnaire, which includes questions such as, my life would be meaningless if I would have to live as a boy, which they would strongly disagree with. Every time someone treats me like a boy, I feel hurt, which they again would strongly disagree with, and so on. The Dutch protocol was considered an innovative practice, which is a rapid advance in the medical field, but is capable of hurting individuals and societies by promoting a non-beneficial or harmful intervention. There is an ethical requirement that, as soon as viability of the new intervention is demonstrated, the intervention must move into a high-quality research setting capable of demonstrating that the benefit outweighs the risk. This never happened, and gender medicine became a runaway clinical intervention. Dutch studies failed to show that the interventions resulted in meaningful psychological improvements significant enough to justify the adverse effects of the treatment, including permanent infertility. Proponents of the affirmation model will say that a lot of interventions in child and adolescent psychiatry are not underpinned by strong evidence due to the lack of research trials conducted on children. However, in my opinion, because the affirmation model poses such a high risk of harm, there needs to be high-quality research evidence demonstrating substantial benefit to justify these interventions. So let's meet some detransitioners, as Corinna Cohen suggested we do earlier. This is a natal male who underwent puberty suppression and estrogen treatment in adolescence.
I wanted to give myself time to really explore my feelings and detransition before I shared them with you. But if you want to see the truth, this is the truth. I'm an almost 30-year-old man. This is what I look like. This is what I sound like as an almost 30-year-old man. This is what happens when you let people transition in adolescence before they've had a chance to grow up. Before they had a chance to even learn who they were. Not just but pressure people to transition at these ages. Young, vulnerable people who are already so suggestible. And I feel like everyone is ignoring the pain because they are afraid that it threatens their choices and their narrative. If you want to transition in your 20s, you've had a chance to be a man or a woman, and this is what you want to do, okay, that's one thing. But the active pressuring of people to transition so they can preserve their femininity, which is what happened with me, I was told that if I allowed myself to age, that I would become masculine and that it would never be possible and that I would do it anyway, and that I would be a more masculine transgender person like them.
This is Kira Bell, who is an English woman who attended the Gender Identity Development Service through the Tavistock in the UK and was prescribed puberty blockers, testosterone, and had a double mastectomy. She's famous because in 2020 she was a claimant against the Tavistock and Portman Foundation Trust in a judicial review case, which is a system which allows people in Britain to bring action against a public body they deem to have violated its legal duties. 3 High Court judges in a unanimous verdict found that children under the age of 16 considering gender reassignment are unlikely to be mature enough to give informed consent to be prescribed puberty-blocking drugs. In 2021, the Court of Appeal found that it was inappropriate for the High Court to issue that guidance because it is an established legal principle that it was for clinicians rather than the court to decide on competence to consent.
Take me back to when you were a teenager then. How did you feel about yourself and what made you decide then that you wanted to transition?
Yeah, I mean, during my teens, it was, I was really struggling, mental health issues, struggling with my sexuality, and just struggling in general with not fitting into the stereotype of, the stereotype that girls are supposed to fit in, society says. And so, yeah, all of this just kind of manifested into gender dysphoria and, was later seen at the Tavistock.
And did you know what gender dysphoria was? Did you feel like you were in the wrong body? Is that how you felt?
Yeah. I mean, I didn't know the term for it before I kind of looked up online. But yeah, once I did, it just kind of made sense. I was like, yeah, that's me, because it explained everything that I was already feeling. I checked every box.
This slide is about the Gender Identity Development Service study, which is the only study that attempted to replicate the Dutch studies with more than a handful of cases. Subjects were recruited between 2011 and 2014. The results of this study were only published in 2021 after pressure from Freedom of Information requests, and the allegation is that the results of this study were buried because the clinic didn't like its findings. Puberty blockers were extended to children as young as 12 at attending GIDS in April 2014, despite the results of this study. This is an uncontrolled, so no control group, prospective, which means going forward, observational study of puberty blockers in 44 children aged between 12 and 15 years who had persistent and severe gender dysphoria with an intense pattern of cross-gendered behaviours and cross-gender identity throughout childhood, which they defined as for longer than 5 years. Children with serious psychiatric conditions were excluded. The measures used were the Child Behaviour Checklist, Youth Self-Report, and CBCL and Youth Self-Report self-harm indices. 44 patients had data at 12 months follow-up, 24 patients at 24 months and 14 patients at 36 months. Now these were not dropouts. These children left the study when they went on to cross-sex hormones. The risks that were discussed with the young people entering the study include symptoms resulting from the withdrawal of sex steroids such as headaches and hot flushes, fatigue, loss of libido, low mood, effects on bone density, and continuation of gender dysphoria, showing that even as early as 2011, the GIDS service at the Tavistock understood that puberty blockers led to the continuation of gender dysphoria, preventing the natural healing of gender dysphoria that occurs across adolescence. At the end of this study, only 1 child ceased puberty blockers, and 43, which was 98%, elected to go on to cross-sex hormones. The conclusion of the study was that there were no changes in psychological function made by the puberty blockers.